All right. Well, hello, everyone. My name is Kunstadter. I'm the Executive Director for the Center for Telehealth and eHealth Law, a 501c3 nonprofit research institute based in Washington, D.C. Our specific three buckets of expertise include telehealth, remote monitoring, and artificial intelligence. We'd encourage you to visit CTeL.org if you have any of those research or policy needs. It is with great pleasure today that I introduce our colleagues, Zach Snyder and Dr. Maria Kunstadter, who will be presenting today on the topic of network adequacy and low acuity care, understanding the gaps. Zach Snyder is with Quest Analytics as an attorney and has a good deal of background in the area of network adequacy and also oral and dental health. And Dr. Maria Kunstadter is here with us. She is the co-founder of CTeL's Oral Health Coalition and the founder of the TeleDentists. And we will be presenting today on the issues of oral health issues and network adequacy gaps within the healthcare system. We're so grateful to have both of you here with us, and I will hand it over to Maria. Maria?
Well, thank you for putting this together, Krista, and I'm delighted to be here. And Zach and I had a great conversation a couple of weeks ago, and between then and this wonderful presentation, I got a notification that addresses the situation painfully from the Missouri Coalition on Oral Health. It said over 300,000 children in Missouri alone enrolled in Medicaid did not receive care because there was no providers in their area. 300, and that's just in the state of Missouri. So what are those children supposed to do if there are no providers in their area? Again, it's network inadequacy. And Zach's the expert on discussing that. So I am very passionate to get access to care. And I think this is an issue that we need to address. And in fact, one of the providers in this interview said that, quote, he said, we actually have people drive 2 hours or so to get to us because they cannot find a provider in their area. And he doesn't understand why dentists won't provide care in those areas, but there's also just not enough dentists around in some rural areas to provide this care. So I call it network inadequacy, and it is driving people, our key competency here is driving people to the emergency room because they have no options, absolutely no options. They can't get into a dentist. There's no dentist nearby. They know if they go to the emergency room, they'll get some relief somehow. So it's driving up healthcare costs dramatically because they can't see the right provider. It's a huge problem with Medicaid and programs because there's ghost lists out there. Dentists will sign up, I think, thinking they're going to do the right thing, but when they call their offices to get in to see them, they say, we're no longer taking it, or we've seen all our Medicaid patients this month. And it goes with other insurances as well. We at the TeleDentist have patients say it's going to take me 6 weeks to see my own dentist, patient of record. That is not acceptable because toothaches, dental pain, dental emergencies don't survive 6 to 8 weeks. Again, they end up in the emergency room. We did actually a survey nationwide in the United States, and dental offices, I am a dentist, shame on my profession, but it's true, only open 24% of the hours of a week. So what are people's options 76% of the hours of the week? If they can't get a hold of a dentist and they can't get into a dental office, they're going to end up in the emergency room or urgent care. And myself and the president of our company were just at the Urgent Care Association annual meeting just this week already. And we had dozens of urgent care centers tell us they just don't see dental emergencies. They send them away. And again, it's like, to me, it's like, what, you send them away? How can we get access to an oral health care provider and not have these people be sent away in pain because it's not what we're trained as healthcare professionals to do. So how this ends up coming to details and statistics is the national and state ER spending on toothaches nationally. Last year, the U.S. spent over $2 billion healthcare dollars in emergency rooms on preventable dental conditions. 95% of those patients didn't need to be there, were not true medical emergencies. So 5% of those patients needed to be there. The other 95% could be handled with teledentistry or other options, or definitely didn't need to go through the whole ER gambit. In Missouri alone, again, I'm focusing on Missouri because they're right next door to us, $8 to $10 million was spent on over 50,000 visits to the emergency room in 1 year in Missouri. And New York, again, obviously a huge state with a lot bigger population, $20 to $30 million was spent in emergency rooms. And again, this was interestingly enough, and this research was especially in urban areas. So I also like to say, rural is not the only place that divides people from being able to get care. It's just not knowing where to get care, not having the funding or the money to get care. So even in dense urban areas, people don't have access to oral health care. And, I can go on with the other states involved, but I know we have to give some time for Zach, but most emergency rooms can't treat a dental problem. The patient's average wait time, if they go to an ER, average wait time is over 4 hours because it's a level 1 emergency and there's broken arms, car accidents, people having heart attacks. That dental emergency patient's going to sit there, usually with 2 or 3, members of their family with them. So clogging up the emergency room to only be seen when they're finally taken back, maybe given a few pain medications and antibiotics and told, go find a dentist. And my contingency is that they already knew how to find a dentist. They probably wouldn't be in the emergency room in the first place. But what that does is statistically 22% of patients that go to the emergency room for toothaches end up as a readmit for the same problem. 10 days later, they run out of antibiotics. Things are starting to heat up again, and they go back 22% of the time, which again is readmits. And the reason is they never got the problem fixed. And adult Medicaid patients are more likely to be in the emergency room than just these 300,000 children in one state, because Medicaid doesn't cover adult dental care very often, and they have nowhere else to go as well. We all know prevention is much cheaper than treatment. Again, an ER visit for dental pain can cost anywhere from $500 to $1,500, where a routine dental exam costs $50 to $200. So we are spending the money in the wrong place, and we are here to offer better solutions to this problem. It is really time that digital health innovation and collaboration drive meaningful change to this issue. It's time to use that collaboration, get rid of outdated models of care, and shape a new era of care together. Again, one of the causes of network inadequacy is geographic disparities. Rural areas have, far fewer professionals going out into the rural areas to serve clients. Workforce shortages. Right now, every healthcare industry has workforce shortages and simply cannot get enough people into their offices because there's not enough staff to take care of them. In fact, dental health professional shortage areas affect over 60 million Americans, and many of those are those children on Medicaid. And then state regulations, for instance, Georgia still does not allow teledentistry. So even when someone actually has access to teledentistry, it's not in the state of Georgia. So teledentistry is being increased and being adopted in so many places to bridge that gap. And thanks to CTeL, we are working on a pilot to put teledentist kiosks in emergency rooms. And Zach has an excellent way to define how that helps with network adequacy. But if those rural hospitals had the teledentistry access so that when someone came in with a toothache, they could be diverted to the teledentistry kiosk and talk to a dentist, get their needs taken care of. And our company takes it one step further and actually gets them into a provider in their network, if it's not even Medicaid, within a week to have an emergency situation addressed. So we really take it full circle, the right patient or the right specialist for the patient for the right condition, and the right treatment and the right triage to the right provider. So again, I highly encourage, as we talk, a way of making this network adequacy, offering teledentistry and access to teledentistry points. Again, I pointed out at CTeL at one meeting, 10% of the population that has a cell phone does not have the bandwidth to actually access a telehealth call. So that's where the kiosks come in. If they go into the emergency room with a toothache, do they need to be run through the whole ER cost and time and et cetera, and wait for 4 hours? No, they could be seen by a teledentist immediately. We're within 10 minutes of most calls and can get them into the right provider and the right care at the right time. So that's pretty much my summary of the whole situation. Zach, I'm going to let you take it over from there, and then we can dialogue a bit.
That sounds great. Thank you, Dr. Kunstadter. Thank you, Krista, for having me here today. So I want to talk with everyone today about Quest Analytics and about network adequacy and ways that, CTeL and your membership can pursue network adequacy credits for telehealth. I have some slides I want to share. I'm going to pull them up right now. And then Dr. Kunstadter, after we talk about this, we can have a bit of dialogue and discuss how the work you're doing can connect with the policy options discussed in my presentation today. So give me a moment while I pull this up. Okay, great. So what I want to do is just quickly start with Quest Analytics, who we are. I'm the Vice President of Government Affairs for Quest Analytics, and I work directly with our federal and state regulators on network adequacy policy. So Quest Analytics is a provider data analytics company, and we focus exclusively on network adequacy solutions and provider directory accuracy. One of the things that really attracted me to this company is that the company is truly dedicated to improving access to care through better data. And I love being a part of that mission. I love working with state regulators to ensure that they're bringing more data into the work that they do to hold the health plans accountable. We work with 90% of the health plans, including dental plans in the country. So 90% of all of the health plans, most of the health plans in the country, hire Quest Analytics to help them achieve compliance with network adequacy standards. And we're going to talk about what those are. But the work that I do for Quest Analytics is really drive our relationships with the regulators themselves. So just like how the health plans, they need a solution to determine how they're going to meet the network adequacy standards, the regulators themselves need a solution to hold the health plans accountable to the network adequacy requirements that they place on the health plans. And we are extremely proud of the partnerships that we've developed over the years. And I won't read all of the partnerships, but on the right-hand side of the screen, you can see who we work with. And these entities use Quest Analytics to ensure that the health plans that they measure and monitor are meeting requirements. So for example, on the federal side, Medicare Advantage uses Quest Analytics. So all of the Medicare Advantage plans that are being measured and monitored for network adequacy go through there. Now, dental is not included in Medicare Advantage. We all know that. And we're going to talk a little bit about that as well. But that's just an example of one of the major regulators that uses Quest Analytics. What do I want to do today? So I want to provide an overview of what network adequacy is from a policy perspective, because when we talk about network adequacy, it can mean many things to many different people. Generally, it's ensuring that that consumers have actual access to care, to a provider that can be able to provide them care. But from a policy and legal perspective, it has a very specific definition, and that understanding that will help us understand what the policy options are to embrace a telehealth credit for network adequacy. So I want to talk about the policy options and then discuss various political considerations and possible messages that could arise if you go down the path of advocating for policy change to include telehealth network adequacy credits. Okay, network adequacy, what is it? Let's start there. The way that I like to define network adequacy is that it is quantitative and objective measurements that health plans must adhere to. And so this includes mostly time and distance requirements to provider specialty type. So the state will, or the federal government will, the regulating entity will determine the various provider specialty types that they want to measure against. Sometimes that includes dental, oftentimes it doesn't. Oftentimes dental isn't even a part of network adequacy. And so the health plans aren't required to demonstrate network adequacy to dentists in order to meet the requirements to sell their plan in a state. It could also include things like provider to enrollee ratios. You need to have one podiatrist for every 200 members in your plan, for example. So that's what I mean by network adequacy. And these are specified in regulation, in statute, and in guidance that the health plans have to meet. And the regulator, they're tasked with making sure that the health plan is meeting those requirements. One of the things that complicates this picture, though, is that these requirements vary based on the jurisdiction and the line of business. So the state commercial line of business that is regulated by the Department of Insurance will have one set of standards. The state Medicaid program will have another set of standards. Medicare Advantage will have another set of standards. Self-funded is regulated by the Federal Department of Labor, and they generally don't have network adequacy requirements. And then you could have even more programs like TRICARE or the Indian Health Service and things like that. And all of these different programs will have different network adequacy standards. And you could even have one health plan that would offer in every single line of business here. So you could have a health plan in the state of Missouri that is meeting one set of standards that the Missouri Department of Insurance sets, that the Missouri Department of Medicaid sets. Medicare Advantage will have their set of standards that apply to Missouri, so on and so forth. So that complicates the picture when you talk about network adequacy, and we'll talk about how that plays into the policy options. In addition to these various lines of business and these various regulators, how the health plans demonstrate compliance also can vary by regulator and by line of business as well. So you could have a proactive filing compliance requirement. That's the most strict level of compliance, where before a health plan is allowed to go and sell their plan and offer their plan, they file their network adequacy data, and the state checks that data and they grade them and say you either pass or you don't pass. If you pass, you can offer your plan in the market. We see self-attestation, though, where the regulator has the requirements, but in order to demonstrate compliance, the health plan is just simply saying we've checked ourselves and we are compliant, and they will attest to that and then file that with the regulator. And then there's response to complaints or alleged non-compliance. So the regulator will get complaints throughout the year, maybe from providers, maybe from consumers. They will then investigate, and then in their investigation, they would ask the health plan to provide data and analysis on their network adequacy, and they could determine compliance or non-compliance through that enforcement action. And that is how compliance would be handled in that state or line of business. Here's an example of time and distance standards. These are the time and distance standards for the federal exchange, right? And I know it's a bit of an eye chart here, and some of these slides, I do apologize, they will be a bit of an eye chart. But this is not all of the provider specialty types. This is just one table of provider specialty types. And this is very typical of what you would see in many lines of business and in many states and in many federal programs. What you have at the top here is a county classification. Every county in the country is classified into one of 5 classifications. And the more rural the county is, the longer the time and distance drive time is in order to demonstrate compliance based on that provider specialty type. You can see dental is a part of this network adequacy requirement. This is for the federal exchange. Dental is only required for pediatric dental on the exchange. So this would not be a requirement for adult dental, although many exchange plans do include adult dental. I did mention that dental network adequacy is handled differently than what we would see for major medical. And a lot of that is driven by the benefits, dental benefits, because we know that dental insurance is very different than health insurance, and it's treated different by regulators as well. That's changing a bit. We're seeing it transform and look, more closely aligned with the way that regular health insurance works. But let's talk a little bit about how this plays out in different lines of business. So in Medicaid, CMS has set a floor for network adequacy when it comes to pediatric dental. So it requires every state include pediatric dental in the Medicaid program, not adult dental. also, in the same regulation that requires that and requires that it be part of network adequacy for state Medicaid programs, the Medicaid program in the state is required to consider the role of telehealth. That is actually in the CMS regulation related to network adequacy. Now, what that means could mean a policy option that we talk about later at the end of this presentation. Pediatric dental, as I said, in the exchange is considered an essential health benefit. And when it comes to the exchange, the health plans are required to report if telehealth services are available. CMS hasn't said exactly how they're going to use that data on the exchange, but they have mentioned in regulations in response to stakeholders that they are using it to decide on future policy that would connect telehealth services to network adequacy in some way. So there's another policy option there. There is no dental requirement in Medicare. However, many MA plans do include dental, and Medicare and MedSup includes it as well. And there's no dental requirement in self-funded either. On the right-hand side, I just quickly, a lot of us know this, just how people get coverage in the United States. This is from the census. So most people that have insurance get it through their employer. So it's a lot of it is a self-funded plan that folks have. But Medicaid is 16.1% nationwide. It's a lot more in some states. I'm thinking about New Mexico, Louisiana. I mean, these are states where a huge portion of the population is on Medicaid. This is across the country because some states haven't expanded Medicaid. And in those states, the enrollment in Medicaid is lower than it is in states that have expanded, like Texas and Florida, for example, are two huge states. They haven't expanded Medicaid, but California has, New York has, and so you see the Medicaid rolls there a lot higher. I did mention that adult dental is an option in Medicaid, and this is from NASHP. This map shows where where we have extensive adult dental Medicaid. And this can change from year to year. When states get in trouble, when the budgets get tight, as they are tightening right now in states across the country, the COVID money is run out, the economy is slowing down, revenues coming into states is going down. And so when they look for cuts, they do look at adult dental oftentimes. I think, Dr. Kunstadter did mention that we had a great conversation. She's a dentist. I have a lot of respect for dentists. I actually started my career working in dental benefits. And that is an area I'm very familiar with. Adult dental is often, when they're looking at making savings in a Medicaid program in a state, cutting adult dental is always on the chopping block there. And this plays into network adequacy, because if there isn't a benefit requirement for dental, then there is no network adequacy requirement. So in Medicaid. Okay, this is a huge eyesore here, eye chart rather. And we'll make these slides available so folks can look at them. Here's just some real world examples of the variation that we see in different network adequacy requirements. And these are 3 Medicaid programs. So California Medicaid, the District of Columbia Medicaid program, and Indiana's Medicaid program. And you can see here for California Medicaid, or maybe you can't see because it's so small, that for dental services, it's 10 miles or 30 minutes for all of the counties in California there. And there's no provider to enrollee ratio requirement, while there is a provider to enrollee ratio requirement for other provider specialty types. For DC Medicaid, you see there that they have a provider to enrollee ratio requirement. It's 1, so you need 1 dentist for every 750 pediatric members. And that's all that the health plan needs to demonstrate in order to meet compliance in the District of Columbia to participate in that program. In Indiana, we actually see them break this out in dental specialty types. That's rare. It's typically only a dentist. So there, you have to show access to different provider specialty types, endodontists, prosthodontists, orthodontists, and so forth. Okay. I showed you network adequacy, time and distance. Regulators are interested in expanding network adequacy policy. So, for example, we see them wanting to engage in provider directory accuracy. How do we make the provider directories more accurate? Provider wait times. Can the health plans report on how long it takes in to get to a provider? Health equity. Can we ensure that the health plans are ensuring access to provider specialty types that are critical to meeting the health equity needs of the population, not just the healthcare needs? For example, instead of just ensuring access to a podiatrist, are we ensuring access to providers that are within walking distance to transit in a metro area like Washington, D.C., for example? And of course, telehealth. So how can we incorporate telehealth considerations into network adequacy, into the regime that I just went over, how it all works today? So Medicare Advantage is a leading example of how regulators are looking at incorporating telehealth considerations into network adequacy, and they're doing it through a telehealth credit. Medicare Advantage is the first jurisdiction to offer a credit, and they did this in 2020 at the height of the pandemic. And so what the regulation says is that a health plan that participates in Medicare Advantage can receive a 10% credit towards the percentage of beneficiaries that reside within the time and distance requirements when they contract with telehealth providers in only these provider specialty types that you see below. So they've picked a collection of provider specialty types. So what does this actually mean? Well, the requirement for network adequacy is that you meet it with 90% of your beneficiaries. In some states, it's 100%, but CMS level, it's 90%. So what does that mean? It means that if you have 100 people in your health plan, you have to ensure that 90 of them are within time and distance to all of the doctors in that provider specialty type. So if you have 90 people that live within time and distance to all of the dermatologists in your network, then you meet network adequacy. So what does this credit do? So what it says is if you contract with at least one telehealth dermatologist that's available to your people, then you only have to ensure that 80 people are within time and distance. That's what the credit is. And so what it does is it allows the health plans to offer a certified network by ensuring that essentially less people have time and distance to doctors that are close to them in exchange for having telehealth providers that are available for them, right? So that is how a credit works. Now, I'm going to talk about why this really hasn't caught fire across the country, okay? There are some states that have done it. California, on their Medicaid side, they have a telehealth credit available, 5% credit. And Maryland, with their Department of Insurance in their commercial market, has it as well. So we have 3 examples: Medicare Advantage, California Medicaid, and Maryland commercial, all have telehealth credits. Okay, so what are our policy options here if we're interested in incorporating telehealth considerations into network adequacy? So there's really 3 different options here. There's legislative, regulatory, and contractual, in order to change the network adequacy requirements to include a credit of some sort. And each come with their different pros and cons. So legislative would be, working through the state legislature to change the statute to require the regulator to incorporate a telehealth consideration. That is a very difficult thing to do, but it is a policy option and has been done. Regulatory would be working with the regulatory agency using their existing statutory authority to create new regulations or new guidance that would create a telehealth credit. So you could identify a state Medicaid agency or a state Department of Insurance that believes that they have the statutory authority to do this, and you could get it accomplished through new regulations that are passed through the typical state Administrative Procedures Act or through sub-regulatory guidance that they could issue. Contractual, this is mostly through Medicaid because the state has a contract with the MCOs, with the managed care organizations, and the network adequacy requirements are actually contractual between the state and the MCO. So you could work with the state to get a telehealth credit, on dental with this pilot through a contract amendment that the state would issue. And that would go through a different process than a legislative or a regulatory process. Now, let's talk about political considerations, because we know where the major players are at on this, because we've seen it proposed for Medicare Advantage. We've seen it proposed for the federal exchange. We've seen it in Maryland and we've seen it in California, and all the different groups come out, right, for this. So let's talk about what this looks like. Okay, the payers are supportive. Why are they supportive? Because it really makes it easier for them to meet requirements, right? Because now they can contract with a more cost-effective telehealth provider, and because they only need to ensure that 80% of their members have time and distance, they get more leverage in their geographic area for that provider specialty type, because the providers also know the network adequacy requirements, and they say, well, you need us to meet network adequacy, and they could drive a higher rate in that contract negotiation. So this gives the plans more leverage because now they have more options, because now they're meeting a less stringent standard, going from 90% to 80%, or if it's 100%, going from 100% to 90%. Providers are divided, but as I have on the right here, AMA, the most important healthcare stakeholder, the American Medical Association, is strongly, strongly opposed to telehealth credits, and they're on record doing that as well. Consumers and advocates, they're also divided, but they really align with the providers on this. And the reason why I know this, I've talked to many representatives of all these organizations. I've read a lot of their letters about this, and they have concerns as well, because it's perceived as a weakening of network adequacy requirements by the providers. The hospital associations, the medical associations, and they bring in the disease advocacy groups that are also very persuasive in states as well. So if you look at it, the payers are really supportive. So think about this from a political perspective. It looks like you're doing the bidding of the health insurance industry, is how it's perceived, when you're looking at something that is perceived as weakening network adequacy requirements. So it takes a lot to get everyone on board, a lot of education about bringing in telehealth considerations into network adequacy. And again, AMA has dedicated a lot of research and time to strongly advocating against what they would perceive as weakening network adequacy requirements. States have also weighed in on this, and they are supportive, because I think the regulators who live and breathe this every day, they see the value in this because it can incentivize the payers to bring in more telehealth providers, and it could also help to make healthcare more affordable, because if the payers are paying, if they get more leverage in the market and their reimbursement amounts go down, that means the rates that they charge consumers can also go down. So the regulators understand that, but this is, again, the political considerations become very, very difficult to overcome. So this is my last slide. Some key messages to think about in engaging in any telehealth credit is to narrowly apply telehealth credits. So not to go across the board with every provider specialty type, and really look at areas where provider supply is already constrained. So like Dr. Kunstadter said, if there's actually no providers in a county or a zip code, then these arguments become really not that strong, because there's no providers there anyway. So we might as well look to bring in, more telehealth providers and give the payers credit for that, right? And then another piece you could think about is not impacting the amount of providers needed to provide and maintain adequacy. So while the time and distance requirements are relaxed from a standard of maybe 90% to 80%, the total amount of providers that they need to contract with should not go down. So if they're replacing, providers with telehealth providers, then, they should still have the same amount that are available. And there's many other messages we can talk about as well, but it is a politically fraught issue, but is something that can encourage the payers to contract with more telehealth providers and increase access to care. So with that, I will stop sharing my screen and hand it back to our hosts here.
Thank you, Zach. This is such a complex issue, but you made it completely understandable. And I am grateful to you and Maria for explaining why this very nuanced issue is practically impacting hospitals and health systems' bottom line.
Yeah.
Do we have any questions? Okay, with that, I would like to thank both of our presenters for an excellent presentation. This will be available online. And if you would like to be in contact with either Zach or Maria, please email us at info@ctel.org. Thank you very much for your time today and look forward to connecting again.
Thank you for letting us vent and discuss options. Solutions is what we need to look at, globally and in the US. Instead of constantly hammering at the problems, we have solutions available. And let's just look at ways of applying those solutions. And thank you for this opportunity.
Yeah,
Yes.
thank you.
This will be part of CTeL's advocacy and policy efforts through our state chapters. So if you are interested, please again contact us at info@ctel.org. Thank you, team. Have a good one. Bye-bye.
Thank you. Bye-bye.
Thank you.